We are ready, and it's my, on behalf of Dr. Gujal Sharma and the rest of the team of Learning General Surgery, it's my proud privilege to welcome Professor Rela to this platform, Learning General Surgery, which is a fairly big platform of over 35,000 members. A large number of them are active, and I also welcome Ashwin. Ashwin, I'm seeing you after a very long time. I wasn't very sure where you were. I thought you were abroad. Anyway, so over to Ashwin.
Okay, sir. Good evening, everyone. So we are now starting a series of talks on liver transplantation on this forum. The first speaker of this series will be Professor Rela, who I'm sure you all agree absolutely needs no introduction. However, if I can take a minute and put his talk into perspective. As we all know, liver transplantation started in 1963. But 2 decades on, as recent as 1984, there was a paper in hepatology by Sir Roy Calne and Professor Roger Williams, the doyens of transplantation, as we all know, in the UK. So they looked at their combined series of King's and Cambridge of transplants over the years, and they found that the 1-year survival was only 22% in their series. And in that paper in 1984, they called liver transplantation a dangerous and experimental procedure. Now, there is also another similar paper from across the Atlantic a year prior to this by Professor Starzl, who also showed similar results. So in essence, it's only in the last 3 decades that we have seen a successful evolution in liver transplant from an experiment to an established cure. And one person who has been in the epicenter of this revolution in transplantation is our own Prof. So, this talk of Prof's with regards to his journey of 3 decades in the field is in essence an insider's view into the history of the growth of liver transplantation. Prof, over to you.
Thank you, Ashwin, for that really introduction. I think that fits in well with what I want. Personal perspective into this. I'm not going to go into the struggles of liver transplantation and how things have been at the beginning. For me, I never saw the struggles in my mind. I saw it as an exciting new field, and I went into it, and I'm always excited about anatomy, and there was a huge amount of anatomy to learn during the retrieval process. As a young surgeon, I saw it as a new exciting field, and I'll talk about how it was an accident really for me to get into liver transplantation, or at the end we can talk about that. I'm going to share my is that coming through? You see?
Yes, yes.
Yeah. So this is going to be really my journey and how I saw it and what my focus has been in the field of liver transplantation. I went there really as a foreigner, and I had to make a difference really to become successful. And as Ashwin said, the survival of liver transplantation has improved tremendously, really, and now you can expect really over 90% survival in the LDLT and probably in the DDLT as well. Now, I wanted to be a surgeon all my life. In fact, when I decided to become a doctor, when I was a young boy, probably I wanted to become a doctor when I was around 12 years of age, perhaps, or even younger than that. And my vision was actually to become a surgeon. And I think that vision to become a surgeon has been fulfilled in this place, the Government Stanley Hospital and Stanley Medical College. I did both my MBBS and MS general surgery in Stanley Medical College. I always wanted to be a generalist, actually. I wanted to be a surgeon who could do everything. And that was my dream earlier on, but later on, I found out that it's impossible to be a general surgeon. In fact, I chose urology because I felt that urology still kept me in abdominal surgery, actually. There was no specialization those days as colorectal. Colorectal wasn't a specialty, or upper GI or HPB was not a specialty at that time. But I struggled hard, really. In the UK, I worked as a Middlegate registrar. I went there as a fairly experienced surgeon. I also had a slight interest in plastic surgery, so I went into trauma for 6 months, and really I demonstrated well my skills really in trauma surgery, because I did hand surgery in Stanley Medical College for a period of time under Professor RV. So really, finally, when I was a registrar in Kent, this was again a middle grade registrar post fellowship. I think I got my fellowship at the same time as finished my MS. I was traveling to and fro, really. I wasn't having a good attendance when I was doing my MS, because again, there I struggled to get into my MS seat for 2 years at that time. So I got my FRCS at the same time as I finished my MS, and went to the UK and enjoyed my jobs as a middle grade registrar, because those days the consultants never came into hospital to do emergencies. So even if it was a ruptured abdominal aortic aneurysm, I can't imagine these days that a registrar would be allowed to do the kind of operations that we did those days. And I was stuck. 5 years went on, and 5 years was the permit-free training in those countries. And many people are asking me, are you not going to go back to India? You've been trained very well as a surgeon. That's when I really decided I have to specialize, because there is no point. The thinking at that time was to go back to India, and to go back to India without getting good, I did not get a good urology training grade post, which would give me a kind of accreditation that was necessary. And one surgeon in Kent told me, go to King's. You might want to do a little bit of liver or liver transplantation. There may be opportunity. And I went to King's and met a surgeon called K.C. Tan at that time. This was in 1991 or 1989. Sorry, this is in 1991. I went to King's in 1989 and met this Chinese gentleman who said, I'll give you a three-month locum job. And I had a 1.5, I had 2-year registrar job in Kent, and I had only done 6 months of it and 1.5 years to go. So I left a 1.5-year job to take a 3 months locum at King's College Hospital. And that's how it started. 3 months locum became 6 months locum, and then it became a 1-year locum registrar, and then a senior registrar. And within 2.5 years of going to King's, I became a consultant. So that was really a very rapid progress for me as an overseas candidate working in the UK. And I can tell you, it's all about looking at opportunities and making the best use of opportunities. When I went to King's in 1989, Ashwin was saying that publication was 1985. That 1985, King's and Cambridge were one unit. It was one liver transplant unit, and King's had the patients because Roger Williams was a very famous hepatologist, and Cambridge had the surgical capabilities because Roy Calne was there as a surgeon. So King's would take its patient to Cambridge and then do the operation. The early days of transplantation, maybe I should tell this story. There was no organ preservation. There was no UW solution to preserve the organs. So the team would take the patient with them to the donor hospital. Supposing the donor hospital is in Lancaster, they will all go by a flight to Lancaster, or they'll go to Manchester. So the Cambridge team and the King's team will go with the patient to Lancaster. They'll do the donor operation and then do the recipient operation. And I've heard John O'Grady say that we traveled with a patient and we brought back a dead body with us. So that's how the mortality was, because there was no preservation. Quality of the graft was not very good. The surgery didn't go well, and these surgeries were done in District and General Hospital in middle of the night. So it was a hugely adventurous undertaking. Fortunately, by the time I went, everything had changed really. The outlook had hugely changed for liver transplantation. And we were already getting around 70 to 80% survival in liver transplant patients. So I've really, this was very early days, and Roger Williams was really personally known to me because he appointed me as a consultant surgeon at King's College Hospital. And Roy Calne again was very well known to me. He helped me a lot really in some of the animal work that I did, and he used to come and watch me when I was doing some hydrodynamic gene therapy in big animal models. And the research. So Roy Calne was very interested. And again, Starzl was somebody that I had met, and I went there to Pittsburgh, and even though it was a short time, stayed there for a short time. And this was actually a picture taken with Starzl when he was there in a meeting in Iran, actually. Many years ago. He's no more. But what I can say very proudly, really, knowing these people, you've got two people here in the picture. One is Thomas Starzl, and other is a person called Professor Ott, who really wrote this paper on pediatric liver transplantation. And he really took a liking for me when I came to King's, and he would actually talk in such detail about pediatric liver transplantation to me. He was trained by Starzl, and he was a pioneer in the field of pediatric liver transplantation. He was in Brussels. So Brussels used to be one of the centers for pediatric liver transplantation in Europe. And in fact, when Professor Ott retired, they had a retirement meeting. And he asked me to come and speak in his retirement meeting, Professor Ott, which was a huge honor for me in those days. So that is how it was. I think the outcome of liver transplantation was very much related to era, and the survival for both pediatric and adult transplantation improved with the era. As you can see, there is a 10-year gap between the survival curves that you can see in the 80s, late 80s, early 90s, late 90s. There is almost a 10% survival each 10-year, and now we are talking about almost 90% survival for liver transplantation, particularly for pediatric liver transplantation. I mean, my excitement when I went into liver transplantation was all about anatomy. I was really fascinated that one can actually dissect out all of these structures so clearly and without any fear, deal with inferior vena cava, aorta. And as I saw myself always as an abdominal surgeon, it was a huge benefit for me to really go through the donor operation. Personally, in the first 2 years when I was a junior level registrar, I had done almost 200, 250 donor operations. Every other day you had to travel, and it was all, there was no regional retrieval those days. We had to travel to every hospital in the country. So we were actually flying in jets those days. Those things don't happen anymore. I think now livers travel, not the surgeons who travel. And it's always when we have had some pretty rough weathers and pretty and scary flights in rough weathers in those days, you know, worried about us and worried whether we are insured to do all those sorts of things. And it was really an exciting time for me. And really how I saw surgery 30 years ago as a liver transplant surgery is not the surgery that we see today. Here is an example of how a cava is clamped above, a cava is clamped below. This is a child with acute liver failure. The portal vein is clamped, and you see everything is blue and congested. And the bleeding, I mean, it wasn't uncommon for us to have bleeding of 30 liters and 40 liters in difficult situations. We have practically moved on from there to liver transplantation without blood loss now. And it was mandatory really in the early days to go on veno-venous bypass. This is not something that I've practiced for more than 15 years now. Since coming back to India for 10 years, I haven't had to use veno-venous bypass once actually in the practice today. And whatever it is that has changed, I think it has changed for the better. In fact, in India, in the beginning, when they wanted to recognize centers for transplantation, this was one of the requirements that they had to do a tick box to say, have you got facilities for veno-venous bypass? In fact, even when I came to India 10 years ago, they were asking that the center should have veno-venous bypass and cardiac perfusionists to manage them, but it's not necessary anymore. I think it's been removed from the requirement. And the operative course, and this is parts that I picked up from my early talks actually, to show how difficult these operations have been and how unstable these operations have been. In the early, this is the chart. If you see the early phase of the operation during the anesthesia, they are very labile, the pressures are low, and then they get filled up and the blood pressure picks up. And during the dissection phase, slowly, really, with a cable clamp, the pressures are slowly dropping and dropping and dropping. And you see the point at which the blood pressure really drops to almost a cardiac arrest stage. This is the reperfusion. And to have heart rates of 30 and 40 and to stop and to do external cardiac massage was not actually that uncommon in the early days. But you look at a chart these days, it's never going to look like this. So the field of liver transplantation, really, the anesthetic techniques have changed enormously, and it is really a teamwork, and that is something that I've learned. And if you really want to have a successful program, and many people, when I came back to India, the worry for them was, how is it that it's not only about surgery? I think there is a huge amount of surgery going well, but it's not just about surgery. It's the intensivist, it's the anesthesiologist, it's hepatologists, your laboratory facilities, interventional radiology, microbiology, good quality nurses. I think it's a huge number of people that are required to make a successful program. Now, so really, I said that I went into in 1991. Sorry, it wasn't 89. I thought I'm getting confused with the dates. I think it is 1989 really that I went, or maybe 1991. And I became a consultant surgeon in 1994. And very rapidly, I became a professor of surgery in 2004, about 10 years after becoming a consultant. Really, I became a consultant when I was 34 in King's College Hospital. That itself was an achievement because my colleague Nigel Heaton became a consultant when he was much older, 38, 39, and he was 2-3 years older than me when he was appointed. He was only appointed a year before me as a consultant surgeon, and it was a huge partnership, really. It gave me opportunity to do and learn so much at King's. I'm really grateful for that opportunity. Now, I was saying when opportunity really knocks at the door, one needs to really grab it if you have the opportunity to do. And we have at that time, earlier on, we have Casey Tan there, and then we had Nigel Heaton, and then we had another surgeon there called David Sherlock, and I was the number 3 surgeon. In the beginning, you are very young and you're an Asian surgeon, and perhaps people don't take too much notice of you, but it's really how you conduct yourself, which or really what you achieve, which makes people notice. And this was one of the very early cases that I did. It was published much later in 2006, but this was a child which was an older child, a 12-year-old child, I think, referred for liver transplantation. You will see that there is an author called Louis Spitz. Louis Spitz was one of the biggest pediatric surgeons in the world, actually. He was the boss of Great Ormond Street. He was a director of pediatric surgery in Great Ormond Street Children's Hospital. And Great Ormond Street Children's Hospital is like the mecca for pediatric surgery. Many people pediatric surgeons would have been trained there. So Louis Spitz called me because he had heard that I was a good pediatric transplant surgeon, and said that I opened this child up and I could not resect this tumor, and can you take this up for transplantation? So the patient came up for transplantation, but I felt that I could resect this tumor. The 3 hepatic veins, maybe I was too adventurous. Maybe today I may not have said that it is resectable. What this was actually a pheochromocytoma. It was an extra-adrenal pheochromocytoma from the retroperitoneum growing into the liver. And the 3 hepatic veins are actually splayed by the tumor, and the tumor was actually at pushing actually growing between the cava and the 3 hepatic veins. So I couldn't tell anybody that I'm capable of resecting it. So I quietly put the patient on the waiting list for a transplant, got a transplant, and got another patient for a backup. This thing happened in 2 instances, actually. It also happened for a patient with hepatoblastoma. So I took the liver out and took the tumor out on the bench and then reimplanted the liver at a very early stage in my career. And that really made people notice that technically I'm probably as good as anybody, even at that age. So really from then on, my interests have been in the field of developing really techniques of liver transplantation. The world of liver, the organ shortage and split liver transplantation was extremely new subject. In fact, Professor Ott was the one who was running a registry for the one we saw earlier on, registry for split liver transplantation, and Brussels were really pushing the technique, and in the UK, we were really pushing the technique for split liver transplantation. One of the reasons we were able to really advance in the technique is because King's was also a big unit for pediatric liver transplantation, and we had we needed to improve on it. And I've had many really publications in British Journal of Surgery. This is the Annals of Surgery publication on split liver transplantation. If you really look at the outcome of transplantation, you will see that they were all very small numbers, and this is a combined series. D.Rela is a combined European series at 98%, 98 patients, and King's, which was my own series, which was published in Annals of Surgery at that time. This is almost more than 20 years ago, this publication in Annals of Surgery. We produced an 88% survival in those days, and 88% survival was as good as really survival, or 90% patient survival, sorry, 88% graft survival, which would mean that 2 patients were probably retransplanted for vascular complications or rejection. So we had a 90% survival for split liver transplant. And if you look at all of the other survivals, it was a much improved survival for split liver, really. And British Journal of Surgery asked me to write a leading article on split liver transplantation immediately following that. And again, we pushed, and I think again, this is an Annals of Surgery publication on the results of split liver transplant in children, and the children results were really much better than the adult results as well. So the life really from then on was focusing on the techniques of transplantation, both for adults and children. In the adults, it mainly in the form of split liver transplant, and in the children, it was really concentrating on small children. And simultaneously, we were also working on really hepatocyte transplant for metabolic liver disease. And this publication is about 1 liver split into 2, and then the segment 4 taken out, and hepatocytes removed, and then transplanted for a 3rd child with really metabolic liver disease. So this was, again, an excitement. Now, the next move for me was really, I think it was, my life was constantly about what next, really. That's been the drive for me all my life, and not only really in the field of there are many interests that I take on over the years, and I mean, whether it's the stock market, whether it's architecture, or it's Renaissance painting, I take an interest and really learn about it in detail for 1 to 2 years, and then really I jump on to the next after 2 to 3 years. And that's really been my life, and transplantation has also been partly like that. So this is one of the early publications. Again, this is over 20 years ago or 22 years ago, where we looked at, this is not entirely my results. This was transplantation for under 3 months of age. And when we looked at the outcome, if you look at the second, almost 50% mortality was what was seen when transplantation was done for children under 3 months of age. So this really was an issue at that time, and many a time we get, King's was again a specialist area in pediatric transplantation, so we were doing a lot of neonatal transplants, that is transplantation within 2 weeks of life or 3 weeks of life for a condition called congenital hemochromatosis, and also acute liver failure in the newborn. So this is a child like that. Where this is a 2 weeks old child, really. This is not the youngest child, this is another one. The picture is another one. Also had a patent ductus arteriosus. So I used to actually at that time also do a bit of pediatric surgery, neonatal surgery, because the surgeon K.C. Tan, who trained me, was a pediatric surgeon. So we used to ligate PDAs as well. I've had one or two disasters in those lines. I'm not going to go into those neonatal surgery. I mean, we were doing gastroschisis, diaphragmatic hernias, all of that were also we were doing at that time. So this child has got you can see a chest drain and a chest incision because the child had a PDA and we had to ligate the PDA before opening the child for a liver transplant. So the situation was this. The reason why we did not have a good outcome for the neonates less than 3 months of age. Less than 3 months of age would be, in terms of weight, these children will be less than 4 kilograms. They're usually around 3 kilograms or 3.5 kilograms in weight. And we fit in an adult split liver. We were not doing living donor liver transplant in those days. So to put a reduced segment 2 and 3 into these children represented a very large liver, what we called a large for size. The liver actually would not even sit inside the abdomen. It's being pushed out, and that causes outflow obstruction and really huge problem. And this publication was one of my early publications, really describing the technique of monosegment transplantation. Again, this is 21 years ago. And this is again, I think, a surgery publication. And here we saw a 50% mortality in very small children for transplantation. And that was really transformed into 1 mortality out of 6 patients, much more than 80% survival or 85% survival in the neonatal period. And that was really a simple anatomical description of segment 2 and segment 3 vein and how to take off the lateral part or the inferior part of the liver. Was a description which made a huge difference really to the outlook of very small children. And this is again a monosegment, which is a split liver, which is further divided for a neonatal period. And this really, again, made a big difference that a child who's, now I've just put that next picture of people I've worked with. One of the problems again was the thickness of the graft. I mean, you can see this child is probably 15 days old or 20 days old. And that's my finger. You can see my hand there with the finger. The liver's been laterally reduced. The liver's been inferiorly reduced, but still it is quite thick. And one of the surgeons who worked with me, Kasahara, was a trainee under me, and Paulo was also a trainee at that time. Now he's become one of the most famous pediatric liver transplant surgeon. He's now the chairman of the Pediatric Committee of International Liver Transplant Society. And I mean, I was a chair 3 years ago. It's a 3 or 4 year position that you occupy. And when he described reducing thickness of the grafts, which we also perform now, and he published that in liver transplantation, and he told me that he learned so much from me that he made me the senior author of that important paper that he published about the reducing thickness of the left lateral segment grafts, because he felt that I've been driving that area. So you'll see all Japanese authors with me as the senior author for that paper. Now, so this is really what I think sometimes we have luck in our life that I happen to have a child at 5 days of age, or this child purely came to me at 5 days of age because this family lost 2 children after birth to neonatal hemochromatosis, which is a congenital, it's a hereditary disease. And they had 1 child, surviving child, and this was a 4th pregnancy. They had lost 2 children. And we also had a very, very good fetal medicine department. It's very famous even now, today. I think most people from around the world go to King's for fetal medicine. There is a surgeon there who can diagnose amniocentesis and intrauterine diagnosis. He, in fact, made a diagnosis of congenital hemochromatosis for this child before this child was born. So the child is from Ireland. The family came to London and had the baby delivered. And after the baby was delivered, the diagnosis was confirmed after birth, and the child developed liver failure, or the liver failure was developed 3rd or the 4th day, and the child was listed and got a an organ, a pediatric organ from a 12-year-old, which was really reduced into a monosegment and transplanted. So I just play this video because I was a very young surgeon. This is all very new to me, to have transplanted a 5-day-old. When I transplanted the 5-day-old child, I wasn't thinking too much about the incidents. It was actually King's College Hospital which got very excited about it and wanted a press conference. This was the very first press conference that I had ever attended in my life. The whole of the media was there, every newspaper in the West, the CNN, BBC, everything covered it. And I think that again made a big difference in my life as to really my surgical competence. I'll just leave you to just listen to this lady.
Because of the anonymity of a donor, it's impossible to thank them. And we'd like to just give our heartfelt gratitude to donors of all organs, not just babies, and appeal that people do give it a thought. The healthiest set of lungs I've ever seen, so very melodious.
This is only liver itself would take about 2 to 3 hours. And a tragedy in somebody's life may cause somebody else's happiness, and for us it definitely has hit our Christmas.
This is the other child who's a well child in the family. You'll see a picture of this child.
Would have died if she didn't receive a transplant in 2 weeks' time, and that's 3 weeks' time, so no. And to wait for a size match organ for this child would be practically impossible. We're never going to find an organ from another child which will suit the size of this child.
So really, that was big news at that time, and I think that that's just been followed up by many people subsequently. And really, one of the BBC writers who did the story, a guy called Martin Halley, 20 years later said that really I want you to meet that girl once again, and he brought her to London when I went to London. Really, she is now a law student in Ireland, and her older sister that you saw is actually a doctor now. And in fact, they all came to Chennai once in one of our MCLD meetings and met our chief minister, and I think our government also got a little bit of publicity because our public got a little bit confused. They thought this transplant was done here. In fact, this is the girl who had the transplant at 5 days of life. So that was an interesting story. And again, it's all about technical developments. And one of the areas I got interested in was auxiliary liver transplant. And my interest in auxiliary liver transplant has been going on for almost 15, 20 years. One of the unfortunate thing about this is that even though at least for acute liver failure, this is a pioneering operation with huge advantages, with the ability to withdraw immunosuppression, which is very practical for our country, at least. You know, patients don't have to be on immunosuppression. It's not an operation which is widely followed and widely accepted. People perceive it as an extremely technically challenging operation. We also did it for metabolic liver disease, and I'll tell you the reasons why. For at least acute liver failure, the principle is that these livers have the capacity to regenerate, but the patients die of septic complications or liver failure or cerebral complication before the liver regenerates. That's the concept. So if you can actually support them during their illness and until the liver regenerates, unfortunately, if this was like an APN, the kidney, or we had a liver dialysis for a short period of time, which has all been tried, artificial liver support's been tried, but the process of regeneration takes probably 3 to 6 months time, because when one gets acute liver failure, the cell loss may be more than 90%, 95% cell loss might happen. So the livers take time to regenerate and the patients get very cholestatic over a period of time. And therefore, the option of really artificial liver has never worked for this condition. But what has worked is actually an auxiliary liver transplant, because you can actually transplant more liver than what you leave behind. And this is an example of a left lobe auxiliary liver transplant. And this is a CT scan for you to understand. The first CT is immediately post-transplant where the graft is bigger than the native liver. We have done a left apoplectomy and replaced it with a left lateral segment. Over a period of time, you can see that the right lobe, which is a native liver, slowly increases in size. And once it increases to more than 50% of its size, you can slowly withdraw immunosuppression. And the right lobe, after a year, becomes larger than the graft, and you can completely stop immunosuppression. So I think we have done many of these in India, but the opportunity to do big numbers has not been there. And this is again a publication in Annals of Surgery stating that most of the children who had auxiliary liver transplant for acute liver failure came off immunosuppression, and majority of them really regenerated their liver. And we also use this concept for critical Najjar, but for metabolic liver disease, there have been many instances where patients have been living for a long time. The reason for doing it in metabolic liver disease is not for withdrawing immunosuppression, but for really waiting for a day when gene therapy is going to become a reality. But we have been talking about this for 20 years. Gene therapy has not become a reality. And unfortunately, for some of these patients, the grafts have become atrophied and have required retransplantation. So the waiting has been too long for them in terms of gene therapy. But I still believe that it's too early for us to say gene therapy is never going to be a reality. And these are all young people. These are all people with metabolic liver disease in their less than 10 years of age. And who are we to say that they may not get gene therapy in another 10 years time or 20 years time? So I think there is still a possibility of doing auxiliaries for this condition, even though the popularity is gone. So this is a critical Najjar patient where the liver is really structurally normal. It's non-cirrhotic. So we replace it with a left lateral segment on the left side. And they will really clear their jaundice pretty rapidly. Immediately, actually, the next day, the bilirubin drops from 25 milligrams to less than 5 milligrams in one day. It's an extremely effective operation. I've also, many of you don't know me as an HPB surgeon. Maybe you know me as a liver surgeon, but I started my life, or at least took on pancreatic surgery as one of my interests, and particularly patients with who require vascular resection in the early days. And I think in the early days, many of the opposed to doing vascular resections for pancreatic cancer or vascular resections for cholangiocarcinoma. I think the experience in liver transplantation has allowed us to push the limits of resection. And if you see many of my early publications, because I was a lead clinician for King's for pancreatic surgery, and King's I think currently does more than 120 Whipple's procedure a year at the moment. So it was really set up by me as really I designated King's as a pancreatic center in London, one of the London centers in pancreatic surgery, and now is really grown to become an enormous pancreatic center. Really, the technical innovations have carried on, and I've come to India. I came to India 10 years ago now, and the ex vivo resections we have done in India as well, where unresectable cholangiocarcinoma, where you can't imagine the tumor is involving all three hepatic veins. Only the lateral part of the left hepatic vein is visible, and the liver is congested as a result of this. There is no way you can offer a resection, because this patient will bleed to death on the table if you attempt a resection with this congested liver. But as soon as the liver is taken out, the congestion disappears, and we have done this in 3 cases really. And again, it's all about extended resections, vascular resections, and the anatomical basis of that. And any of you are interested in reading about hyalocholangiocarcinoma and advanced resection for hyalocholangiocarcinoma, this would be a very interesting read from Langenbeck's archives, where we describe an anatomical basis for extended resection in cholangiocarcinoma. And this again is a technique published where you go very laterally to the left portal vein that you see, and then do the resection as an extended resection. Perhaps they may require portal vein embolization, but I'm not going to describe this procedure, but it's a very, very innovative procedure. Now, Now I'm really doing well in King's, been appointed as a professor of liver surgery in King's. But the developments in liver transplantation are now shifted to the east, because the next development in liver transplant was really the living donor liver transplantation, and the opportunity to do living donor liver transplantation in the UK was not that much. We did start living donor liver transplantation, but there was a huge amount of cadaver donation available, and ethically to really offer a living donor for patients when there was an opportunity to transplant them with cadaver livers was really was a problem in developing numbers. So we were actually offering living donor for overseas patients only, but then that was not giving me enough experience. So that was one of the reasons when I took a move, and part of the reason I moved to India was at that time, the owner of Gleneagles or Global Hospital, Ravindranath, was a close friend. And I shouldn't say at that time, I think he still is a friend. Not a close friend anymore, obviously. He really told me to come for 1 year. I think he tempted me to come for 1 year and experience how things are in India. So I took a sabbatical for 1 year because I was a little bit skeptical, and came to set up a liver transplant program on a 1 year sabbatical. I came here for 1 year, and in the first year itself, I worked both in Hyderabad and Chennai because it wasn't that busy, but still I did 60 transplants in the first year of coming to India, and that was a huge encouragement for me. It gave me an opportunity to really develop expertise in living donor liver transplantation after coming to India. So I decided to stay back in India. So I resigned. I mean, I had some contract in London for many years after that. It's only 2 years ago that I resigned completely from King's College Hospital. And now I work entirely in India. Again, it was all about finding out a problem and finding a solution for the problem. And one of the problems in living donor liver transplantation is what is called small for size syndrome. I think we have done a lot of work, and we are able to transplant. What you must have heard about the word GRWR, which is graft recipient weight ratio, which should be at least 0.8% of the recipient's body weight. So if a patient weighs 70 kilograms, for instance, the minimum amount of liver that you can give them is about 560 grams. And if the liver volume is less than 560 grams, then they suffer from really poor outcome. That is a publication which came from Japan those days. I think now we have got a much better understanding of why you can't use small livers, and why there is an increased blood flow through a small liver can damage the liver. And we have really devised many techniques, and now we can use smaller and smaller liver. And 2 years ago, if you had heard my talk, I would say that I was constantly looking at reducing the size of livers, that if we can only transplant a left lateral segment into an adult, that would be an ideal situation. And I think if we understand this subject better, I don't think we have a full understanding of this subject. I believe in the future, we may be able to transplant a left lateral segment safely into an adult. And again, I won't go into the details of that. There is a huge amount of research that is required. But what is striking for me and for anybody who is involved in the field of liver transplantation is transplantation changes lives. And you can see this child with biliary atresia. You can see the scar on the abdomen with dilated veins, who's desperately sick. 3 months later, it can transform the life of this child into something like this. I think at the end of the day, we may come across disasters in what we do occasionally, but what keeps us going is really that the outcome that you get, such a fantastic outcome that you can get with liver transplantation. And I was, after coming to India, I have to say I was able to do everything. Many people were skeptical about me coming to India. Many of my colleagues in King's College Hospital said that I would disappear from this specialty. I would not be recognized as a leader in the specialty. And they gave me many examples. I mean, they even gave me examples of Mr. Casey Tan, who was my boss, who went to Singapore. The numbers, they said, would not be there. The facilities would not be there. And I think they were all completely wrong. And I have to say that I enjoy what I do much better here than I enjoyed in the UK. And I have to say that the colleagues and the trainees that I have in India are actually far, far superior to the trainees that I've had in the UK. So I think Indians are inherently very able and very superior, technically superior surgeon, and I have no doubt about that. And I think it's highly possible for us to advance in this field in India. And again, one of the criticisms has been whether I would do academically well, and I think that recognition continued to be there. I've been given review articles by transplantation, by liver transplantation journals as invited articles, and we have actually continued to be very innovative after coming to India. And this is one of the publications, I think, which is a very important publication of carrying on with auxiliary liver transplants in India. So this is something like a swap. This is really a transplantation without a donor. So if you have two children with two different metabolic liver diseases, and if they are single enzyme defects, for example, so this is an example of one child with Crigler-Najjar syndrome and one child with propionic acidemia. You just swap the left lobe between the two children, and the metabolic liver disease will be cured for both of them. And we did as a one single swap, really. A child with Crigler-Najjar received a left lobe from a child with propionic acidemia, and the metabolic abnormality was corrected by this propionic acidemia liver, because this propionic acidemia liver does not have the defect of Crigler-Najjar syndrome. So you could actually do transplantation, and this was really very exciting for liver transplantation, that they even wrote editorial on this paper. Even though this was only a case report, they wrote an editorial on the subject on this paper. In terms of numbers, if you want to know whether I've been successful, I think I've been extremely successful in the numbers. In 10 years, we have done over 2,000 liver transplants, 1,600 adults, and 456 pediatrics. And our pediatric program is probably one of the largest in the world. We can't compete with some of the Chinese centers, and there is probably one Russian center which is larger than them, but our pediatric program is larger than any center in the United States or in Europe. So we do now more than 60 pediatric liver transplantation in Chennai. And this is what shows last year, 2019, I think we did 67 pediatric liver transplantation. So really, in terms of advances in pediatric transplantation, we're not inferior to anyone. And in that recognition, really, I was made the chair of the Pediatric Committee for International Liver Transplant Society 3 or 4 years ago. In terms of really how we offer the services not only to the patients in India, we've been offering services to patients in the Middle East, and everything that we have done, we have tried to do it in a very formal manner. This is the Ministry of Health from Oman, who came and visited about 6 hospitals in India and chose us as a center for provision of services for the whole of their country. So any citizen of Oman who needs liver transplantation or any liver services, the government will only fund them if they come to our center. So we have had this relationship now for almost 8 or 9 years, and we are continuing that relationship. I think with the COVID time, all of this has stopped. We provide a large service for patients from Sri Lanka. We have probably transplanted now over 100 children from, 100 patients from Sri Lanka as well, which is our neighboring country. We have been training a large number of our own people. We have been training the Middle Eastern fellows, and we take patients obviously from MGR University, from MMC and Stanley. The surgical trainees come to us. We have surgical trainees coming from Oman and other Middle Eastern countries who spend 3 months and 6 months time with us. This is a surgeon from Sudan who trained with us, and we have really trained a large number of patients. What's important also is really making the government understand that the outcome is very good, and we've been very fortunate in Tamil Nadu that the government funds transplantation. So I brought the health secretary for a reunion of children who were transplanted with government funding. So the government has funded a huge number of children for transplantation, and it was very important for them to see how well these children are doing. This is a kind of education for the public, education for the government also, to see that the money that they are putting on these children is not wasted. So this was a reunion of children. I think I don't know if I should say son of the soil. I'm from Chennai, and many people know me in Chennai. If you ask, many of them will say that they've known me even as a medical student. I've been recognized with a Lifetime Achievement Award by MGR University, and I've also been recognized with a DSC, and that was really given by the former Chief Minister, Ms. Dr.Rela, and the Governor of Tamil Nadu. So I'm very grateful for the recognition. So I've had all the recognition I can think of locally, and I've also had the recognition internationally. I've been elected the president-elect of International Liver Transplant Society. I will be the president of ILTS from 2022, really. And for those who have criticized that I may not do academically well, I think I've done extremely well academically after coming to India. I think in the last 10 years, I would have had more than 200 publications. I have a H-index of 58, and I have citations of more than 11,000. So it's not actually stopped after coming to. I think if you do good quality work, and if you have good quality people working with you, I'm pretty sure that it can be published. And if you look at PubMed, and this is just a search that I asked Rajesh to make, from 2010 onwards, I've had more than 100 this. I think there is a shortage here that I've had more than 189 publications after coming to India. And I've also been honored, really. I've been asked to write a chapter in the last edition of Gray's Anatomy. And you'll be surprised to know that the chapter that I wrote on was not on liver. It's in fact on pancreas, anatomy of the pancreas, because a person who knew me, who asked me to write that chapter, in fact knew me as a pancreatic surgeon more than a liver surgeon, because at that time I was a lead for pancreatic. When he knew, he trained in King's for a short period of time. He was professor of anatomy in, not the editor-in-chief, the sub-editor who asked me to write was in fact working with me in King's. So he knew me as a pancreatic surgeon. So I've been given the opportunity to write a chapter in Gray's Anatomy, and I've also had now the opportunity to write a chapter in Bailey and Love as well, which will be coming next. And we've also been conducting educational classes, which is called Masterclass in Liver Disease, which is hugely popular. We have about people attending from 25 countries and over 1,000 delegates which come. And again, it's moving again. I've 2 years ago made a move, and many people would say, why move when you're doing so well? What are the issues? There may be, I mean, I'm not going to go into details. Some of my own colleagues were very unhappy that we were moving, but I'm extremely grateful to my colleagues. When I made a move from Global Hospital to the current Rela Institute, 270 of my staff came with me. So it was not difficult for me to really reestablish. Again, it was about a dream of trying to do things the way I wanted to do. These are our staff when we went to Kodaikanal, really. About 100 of us went. So most of them, and it is really about setting up something the way you want to set up in a new way. This is our intensive care unit. We have 24 beds in liver intensive care, where liver transplant patients and patients with decompensated liver disease or HPV patients are admitted into this unit. And this has been really my dream, to set up world-class liver unit. And I think that dream has been fulfilled in the new institution. And keeping still is not going to help. And the world keeps moving, and things are becoming minimally invasive. This is my last slide to say, today has been a remarkable day. We have done our first robotic case with the Da Vinci Xi system. It's only a start today. We did part of the donor operation using the Da Vinci system, and we hope that we can develop this and move on along with the field and along with everyone else, and hopefully be successful in this as well. Thank you very much.
Well, thank you, sir, for such a mesmerizing talk, and we are really amazed to see history unfold in front of us, and narrated by the person who created history. It's really, really wonderful listening to you. Ashwin?
Yes, sir. As always, Prof, it's inspiring to hear you talk. If I may indulge you in a few questions, which I'm sure quite a few of us would also have had during the course of the talk, and something which we have discussed in person as well. If you had not gone to the UK and you did do your MS General Surgery in Stanley, if you had not gone to the UK, or say if you had not taken liver transplantation, do you think you would have been as established or as famous as you are today?
How can I answer that? I don't know. I don't know. There would have been many surgeons. See, I used to think that maybe, I don't know if you've heard about Raja he's a surgeon in the south, Pollachi. He was the SHO and a PG above me, and I used to admire the way he did surgery. And he was an extremely capable surgeon, and what he was doing was really towards, even before he died. I mean, he died of a dissecting aneurysm, and I hugely admired him in my young days. And he had instruments in his in the back of his car, and everybody was inviting him to operate, and he was going from nursing home to nursing home, but providing an excellent service to his patients, I'm pretty sure. Maybe I may have had a life like that because I enjoyed doing surgery. I always wanted to be a general surgeon. Or maybe, who knows, I may have become a urologist if I had stayed here, and maybe I would have taken on robotics much earlier and been a good robotic surgeon. I think it's extremely difficult to say. One Irish surgeon who came to King's when I was a registrar said to me, you know what, you're a chancer, he said. He said, you take chances. You would go anywhere where you see an opportunity. And he said, you'll do well because I know that you would take chances with everything in life. I think that was probably a good description of me. I was quite shocked that he said that to me. Maybe I am a chancer. I take chances. When I get an opportunity, I try it out, and I'm not conservative. I've always said the way I operate now is not the way I learned surgery. The way I do things now is not the way I used to do things. So I keep moving with time, and I focus on a problem and try to find a solution to a problem. And that's what's helped me over the years to keep moving on. And that also probably, I mean, I don't move from place to place. In fact, I've only moved from King's to global to here. And it's taken me 10 years to move 20 years to move from King's, 10 years to move from global. And I don't know how long.
Sir, there are a couple of questions in the chat box. Before I open it to the audience, they'll all have their own questions. How do you write so many papers? Do you have people to write for you?
No.
Because many Indian surgeons don't write well.
Yeah. I have to say, I write as well. I have very good people. Ashwin, as you know, is a huge writer. I always think that, I mean, I edit them, I give them the idea, and if things don't work out, I write, and I have to admit today that I don't write most of the paper. It's my ideas, and I do the corrections and shape it up is what I do now. I have many surgeons now who are all extremely academic. You've heard about Dr. Srinivas Reddy, you have Ashwin, we have another surgeon called Abdul, there is Rajesh. I tell you, how lucky I am to have the colleagues and the fellows that I have. I think I've attracted good people to come and work with me, and I've been able to retain them. And this COVID time, you have to look at the literature to see how many COVID papers we have written. We've all become COVID doctors in the last 3 months when we have not been doing. We have managed more than 700 COVID patients in our hospital now. And every one of our liver doctors will know everything about COVID. So you just have to look at the literature. The COVID papers are coming out right, left, and center currently. So
Wonderful, sir.
What we've done.
Dr. Mohamed Niyamatullah wants to know, please guide us regarding joining as a trainee in Rela transplant program. I'm a SGA resident.
No, I think they just Ashwin is the man to contact. Ashwin is the man to contact. He is our academic head. We actually don't have a space for maybe another year or so because all our fellows are really there and they've not moved out. And therefore, the person to keep in touch would be Ashwin, and when an opportunity comes, he'll let them know.
Well, another related question by Dr. Mahesh. What suggestion would you give to MCH surgical gastro residents thinking of choosing a liver transplant career in liver transplant surgery? What is the advice you would like to give? How to go about?
It's about passion. It's about hard work. If you want to, I think if you want to choose it as a career because it's going to be lucrative, you would lose actually. It's not. It's highly competitive now. The field is highly competitive, and you can't just set it up in every hospital like any GI surgery. It's going to be limited to, even though there may be many centers, it's the numbers are always going to be concentrated in the larger centers, and the ability to perform really high-level surgery will depend on how many transplants that you're going to do. If you're going to be a center doing 20, 30 transplants a year, you will always won't be able to take risks. You will have to do only safe surgery and standard surgery. I would say if you're passionate, you need to be part of a large team rather than be a single surgeon trying to do things yourself. And therefore stick to big units and stick to staying in big units to become successful and to continue to learn over a period of time.
As an extension to your question.
One last question before going to Ashwin. Dr. Kanchan wants to know what inspires you to do animal experiments.
I think, see, the early days when the first set of work I did on animal was because when I went to King's, I had to survive and I had to build my CV up, and it's such an academic institution. So I did some work on chronic rejection, and at that time, nitric oxide was very famous. In fact, that is something that I did not focus too much on that in my CV. I used to work for somebody called Moncada, who discovered, Salvador Moncada, who discovered nitric oxide in humans. So I used to do heart transplants in the neck of rats and give them nitric oxide synthase inhibitors. And he is the one who discovered prostaglandins as well. And he was nominated for Nobel Prize as well, even though he didn't get it. So I used to work for somebody very important when I started doing animal work. But later on, I had an interest in gene therapy because of oxalated liver transplantation. So I used to work with a professor. So we worked on an animal model for really delivery of gene therapy called hydrodynamic method for gene therapy. So I did some pig work on that. Currently, my interest is something really very anatomical on liver regeneration. And I've been wanting to do this for many years now. And we just set up an animal lab in Global, and then I left, and then it's taken another year and a half now to set up the animal lab here. It's shaping up nicely. So it's going to be done to address a specific problem that I want to understand. So that's what I'm trying to do. It may come to something or it may not come to something, but that's the next work I have in mind for an animal model.
Ashwin, before I come back to you, one interesting question, very interesting question by somebody called V to Professor Rela. Each and every step into something new, how did you overcome the anxiety of being judged by people and colleagues when things go wrong, sir?
I think that's a very, very good question. The biggest worry is really when your colleagues don't support you. I was very fortunate that I worked with a colleague and we worked in such close partnership. We supported each other, and we knew the strength of supporting each other. I'll give you one example of the auxiliary liver transplantation in early days. I did an auxiliary on a child with mushroom poisoning. The child was extremely toxic before the operation. And I did an auxiliary, and the child went back to theater. And the next day ward round, King's has ward rounds with 15, 20 people in it. And one of the hepatologists, the child was still sick, was requiring inotropes, and said to me in the ward round, you shouldn't have done an auxiliary for this child because you've left the native liver in and the child is toxic and this is not going to survive. If that child didn't survive, 20 people in that room would have thought that I'm experimenting on that child. But I said to him, and my colleague said, that the child was not sick because of the toxic liver. It's because maybe there is still not good enough liver function. And the child survived and came off immunosuppression. So I think our life is made by how good our colleagues are. And if our colleagues are pulling us down, we'll never be able to progress in our life. I think I've been fortunate. But I never really had huge worry, really. When I was appointed as a consultant, the first opportunity, again, opportunities come. It's amazing how they come. Like, I have a senior colleague, and I did the 5-day-old child at a time when the senior colleague was on leave. Otherwise, it wouldn't have been me, for instance. It would have been me and Nigel Heaton. So it's Kwahali is me because and I didn't have the worry about doing it. And again, when I did my first split liver transplant, people said to me, are you not worried about doing this? Because before I did the first split liver transplant, 2 split liver transplants have been done by Casey Tan with a 50% survival only. One patient in every one of those split died. And when I did the first split liver transplant, everybody said, you're confident to do it. I did not worry about the technical aspects of it at all. To tell you the truth, I was a much more confident surgeon when I was younger than I am today. Maybe I was too rash a surgeon those days. I'm, I think, much more calmer and slower, and I've not slowed down because I've become old, I think, but I've probably become more thoughtful now.
Ashwin.
Sir, to ask you another question with regards to your life in the UK. Now it's like what you said, in the last 3 decades, the education, surgical education, the technology has changed in India, and India is not lagging, in any way with regards to the to surgery as compared to the West. If you were a fresh surgical graduate, would you still go to the UK?
The answer is no. I don't think. See, if I was sitting here and thinking about surgical training, I wouldn't have gone to the UK. You know what? The reason I went to UK was not about surgical training. The reason I went to UK was because I was a failure here. I struggled to get an MS seat. And I didn't get an MS seat for 2 years, and I decided I'm not going to stay here. I'm going to go and get my FRCS instead. But when I was actually preparing to go to the UK, the system changed in India, in Chennai, and then they introduced the first entrance exam. And I took the entrance exam and I got an MS seat. Before they introduced the entrance exam, I did not get an MS seat in India. But then I decided to go, so I finished my MS and went to the UK. I think currently, in terms of producing a good quality surgeon, I would say that there is actually no need to go to the West. But if you plan to go to the West, there is a distinct advantage. When you return back, as a person, you are a very changed person if you are trained in the West. I think I still see there is a difference between surgeons who have been trained in the West and the surgeons trained here. I'm not saying surgeons trained here or in any way inferior. In fact, some of the surgeons who work with me who are trained here are quite outstanding. I mean, Rajesh, for example, is extremely outstanding. So, but what it gives you is an additional confidence that you feel that you're not inferior to any Western surgeon. Maybe people who are trained here who see a big Western surgeon might think, oh my God, he's a big guy. But if you worked with them there, you know that he's not any different from you, or he's not superior to you. So it removes an element of inferiority complex, and it gives you an element of confidence. And also, I think there are many things that maybe we have spoken about. Your values are different, and one of the problems I see of people, I think there is a slight problem with valuing life by the general public and people, and or maybe it's my perception. I don't know. I don't think there is a need to go abroad, in short. But if you happen to go abroad, I don't think it's a disadvantage either. I put it that way.
I just have one last question. Sorry, if I may ask Prof this. It's like what you always ask: what next? Now that we did do a robot-assisted donor hepatectomy today, what next? Do you think in the next 10 years liver transplantation will become obsolete? Where are we going? Where do you see us?
Whenever I talk about future of liver transplantation, I say that the future of liver transplantation is that it fails to exist as a surgery, actually. I always say in 50 years' time, in 50 years' time, we'll look back and think, how did we do the surgery? It's such a crude surgery that people used to think about replacing a liver, which is damaged. So I think maybe the future of liver transplantation is that it won't be a surgery anymore. There may be that there'll be other treatment options. Can I just give me 1 minute? I just have to answer the phone. Somebody calling me repeatedly. You can think about a question. 1 minute.
Yeah, I'll ask Dr. Jayanti to come in, unmute, and when Prof comes back. Yeah, Dr. Jayanti.
I'm back.
Good evening, Prof.
Oh, good evening.
Yeah, I'm Jayanti here.
How are you?
Can you put your camera on, man?
Oh, I'll speak to him. So, awesome talks, as usual, down the memory lane. You've been, I mean, during our stay in Global, I think you were one of the main mentors where I always was struck by your
Thank you, Dr. Jayanti. Come on, you saying that.
No, because of that, I started writing papers in hepatology. Otherwise, it was more towards a gastroenterology oriented. And I think I had quite a few papers and publications, largely because of your thought process, which also got us interested in that.
Thank you for that.
And thanks to you, today I'm also heading a department of hepatology, and we seek your blessings and guidance. And of course, not to miss your Kambara in Tamil Nadu chapter of the ISG. I think many people do not know that. I think it is, we asked Sir when he does that, he says while taking a flight from India to London, he would read about Kambara and come out with and it is awesome, some of those. So thank you very much, sir, for a wonderful talk.
Thank you. Thank you for those kind words. I think it means a lot to me when you say that. Yeah, I think actually if you search me in YouTube, what comes up would be actually not my talks in liver transplantation. It'll be Kambara talks, which come up more often because it's listened by more people than my liver transplant talks. Actually, I've got a much better audience on that.
A few words on Kambara, just for people to know.
No, I don't think. What do you want me to say? No, it's okay. No, I don't want to do that now. We'll do that later.
Ilango Setu.
Prof. So it's always inspiring to hear the stories. I think I've loved hearing the stories from you several times. I enjoyed every bit of the talk. For the sake of the youngsters, I have a few questions. What is the appropriate training before a young surgeon can go in for a liver transplant fellowship? Should they do it right after MS? Should they practice for some time? Should they go for a specialty and then take up liver transplantation? What would be your advice?
Yeah, I think right after MS is very raw. I think that's too early for somebody to get into high-level surgery. I would say anybody who's done 2 years post-MS in some who has matured as a surgeon, it would be appropriate. But I have no problem. I think I'm very happy to train people who have just done their MS, and we have trained people who have just done their MS. But one of the problems that they might face when they've just done their MS is, particularly in India, I think nowhere else in the world is this problem. There are people who would have done their MCH GI surgery or MCH HPB surgery who will actually make claims to this area more than somebody who's just done an MS. So there's a danger there actually for them in the long run. I think, I mean, we have had one surgeon who just did the MS and he's in Pune now, who's doing extremely well. I think any some sort of surgical experience, maybe some fellowship or 1 or 2 years of surgical experience and some maturity before doing liver transplantation would be useful. And if that time is done by doing some MCH, upper GI or lower GI, that's not a bad thing either. But I wouldn't say it's mandatory that they should have had their MCH qualification before doing liver transplantation.
And as a second part of that question, what appropriate technical skills would you expect in a trainee who starts his liver transplant training? What would be a teacher's view on these things?
No, I don't think you need really any special technique. In fact, most of the finer techniques in liver transplantation is in fact microvascular surgery or vascular surgery, venous. And so I've known, like Sudhindran went into liver transplantation being a vascular surgeon. There are some urologists who went into liver, urologists went into liver transplantation. Some kidney transplant surgeons have gone into liver transplant surgeon. So I think every area of interest helps, but I think the right way to go about it would be to combine liver surgery and liver transplantation together. In the US, actually, it's not liver surgery and liver transplantation because HPB surgery is a separate field, and liver transplantation is part of transplant training, really. In the US, transplant surgeons do liver transplant, kidney transplant, pancreas transplant, whereas where I trained, really HPB surgery together. I think there is a huge opportunity for the two surgeries to help each other. I think you will find that a surgeon who does liver transplantation would do much more aggressive HPB surgery than a surgeon who's just done HPB surgery alone.
I'll take I'll take one more last question.
Yeah, last question. There's so many others who want to, but I think.
So this is a technical question, Prof. I have noticed that, I mean, when I was taught liver transplantation in US, I was always asked to sew towards myself. But when I saw you here, I was very surprised that you start from the lower end and you sew away from you. Is there any particular, I learned that technique from you, but is there any particular reason why you
No, I see that the thing is, it's not truly, when I do portal vein, I do the back wall away from me towards me, and then I take the other end and again away from me towards me. The portal vein is as you described. The only thing that I do differently to most people is the right vein anastomosis. That's the only way I go from below, because I think the way the needle is positioned, I've just got used to that. Again, it's not just both of them going away from me. I go from below upwards and then come from above downwards. So I go both directions. That's the only anastomosis I do in the opposite. So everybody asks me that question. It's just I've just got used to it. I think if you look at the artery or if you look at the portal vein, I just do it the way everybody else does.
Thank you, sir.
Dr. Balchandar?
Hello, sir. Hi, how are you?
You can put a camera on, TGB.
Yeah. Actually, excellent talk by Dr. Rela. If I remember, in 1986, when I joined as a school officer in the Professor V. Chandrasekharan's unit.
Yeah, CCS, C. Chandrasekhar.
Yeah, yes. That time I remember Dr. Mohamed Rela was just going out of the final year student of MS.
Yeah.
So he was a very fond student. VVC, Chandrasekhar, he was a very fond student of VVC. He used to tell me about him, some time back. And I remember I never had much exposure with him because at that time he was busy in preparing his thesis for MS, I remember.
Mm. Yeah.
And also he just finished his FRCS final or something. And he was very, he was preparing for his exams because the university, I think, preponed his examination 6 months earlier, if I remember.
Yeah, but yeah, that's true. I didn't have an attendance actually, and then
Yeah,
they
yeah.
actually allowed me to sit the exam.
Yeah.
Dr. CMK Reddy helped me with that.
Yeah. So he had to.
I went off to do my part 1 FRCS and I also did my part there and
yeah. So
a little bit. And
your schedule was too much tight packed. I was able to see.
I cheated a little bit at that time.
Yeah. So he was so busy at that time. I never had much exposure with you, but I used to get all the information from VV Chandrasekharan because we often used to meet. It was a very good unit.
It was a good unit.
Yeah.
We had Raja, who died. I just mentioned his name. I really liked him very much.
Yeah.
I went to his house actually to see them.
Yeah.
And then Darwin was also, Darwin.
Yeah.
He was also they were all SHOs with me, and then they became PGs because we all didn't get a seat immediately at that time.
That's correct.
Yeah.
So then ultimately you just finished your MS, you got up with the first shot and you left. That's all.
I left 4 days after I got the results.
Yeah, that's what. So I never had the opportunity to meet you, but I used to listen much about you from VVC actually.
Okay.
And because it was an excellent unit, more of academic interaction and all those things. Anyway, I am very much happy that you are one of students of VV Chandrasekharan. And I don't know whether you know him, he's still alive.
He's still there.
Yeah, he used to, whenever we suffered from, and now I think he's almost in his 80 plus or something.
Yeah.
And he's very happy.
He lives in the same house. He still lives in the same
That's correct. So,
thanks. Thank you.
Thank you very much. Thank you.
Dr. Shruti, what is your question? Shruti Reddy? You can, please. Dr. Shruti, are you there? Anybody else wants to ask a question? Actually, Shruti wants to know what are your views on DCD in India? When do you think that we'll be ready for it? And what do you think the future of transplant in India in terms of living versus cadaveric?
I think the future needs to be improvement in cadaver donation. That is for sure. Perhaps the proportion of cadaver, there has to be a balance. At the moment, I think 90% of transplants are living donor, and the cadaver numbers are not improving. I think we need to work. I think we need to be like the Western world, where the public and the profession understand about organ donation. DCD, I think I still think it's very premature for India. The law needs to be tightened up completely for that. I don't know how many people know about DCD. It's about, they're not brain dead. It's about withdrawal of treatment and allowing somebody to die which might actually also include, I mean, these are patients who are hopeless in terms of their survival. I mean, there are instances where you actually physically extubate them and then wait for a cardiac arrest and then retrieve an organ. I think that will really shake public confidence. I don't think our public are still entirely really will understand DCD as a concept in our country. Even one or two complaints. See, I've had situations in the UK where somebody has been declared that they will not survive. We have had patients who have been extubated because I was involved very much in the DCDs in the early days. King's was very involved. There are many publications I've been involved in. We have extubated patients thinking they're going to have a cardiac arrest. There have been at least 2 instances that I know of that the patients have survived after extubation. And I think there has to be a maturity in the medical community as well as the public to accept that that is a possibility. But in India, I think it's I would fear about DCD. I don't think even I'm ready for DCD in this country.
Thank you. There's somebody with a raised hand. Please ask your question.
Hello, sir. Good afternoon. It was an amazing talk, and I'm a surgeon from Sri Lanka. I have seen you 7 years back in Colombo, and it was you gave an inspiring talk that time as well. And my question is, do you all offer training placement for overseas training like Sri Lanka, who are consultants in Sri Lanka?
I mean, you have many surgeons in Sri Lanka now who have been trained abroad. I know the surgeons who are doing liver transplants who are actually trained in King's itself. I mean, there have been people, and we know quite a few surgeons who are quite good there. But what's not happened in Sri Lanka yet is that liver transplantation has not really become a reality yet in terms of numbers and the outcome. And that, I mean, India was going through that phase for many years. I think it will change with time. I don't know much about your public sector hospitals and how, whether private sectors are going to take this on and make it a success, because the private sector hospitals in Sri Lanka are not as developed as they are in India, I think. So the transplant activity is still going on in the public sector. I think there is still the donation numbers, living donor transplantation outcome are still not fully established there. And that's why the patients are traveling abroad. It's not that you're not having patients. I think we transplant a large number of Sri Lankan patients. I think it's a question of time. It will change.
My question is, so do you offer training placement for Sri Lankan training?
Yeah, we are happy to. Yeah, we will be happy to. I think you should ask Ashwin. It depends on how long you want to get trained and whether we have a position. Yeah, we have been training people from abroad as well. We are actually part of a university, and it can be an accredited fellowship position overseas as well. Previously, with MGR University, we had problem with overseas trainees. We couldn't give them university fellowships because they were only accrediting local fellows, Indian doctors for fellowship. They were not encouraging overseas doctors. Now we can actually offer for overseas as well, university accredited fellowship.
Thank you.
Thank you.
One Dr. Virendra Swami from the Facebook group asked a very specific question. Sir, what is the evidence-based information about mitochondrial rejuvenation in liver transplant and graft survival?
I have absolutely no idea about the subject. I don't know if there are publications on the subject. I don't know how one would rejuvenate the mitochondria within the liver cells. If he's got
hello sir.
Hi.
Hello sir. This is my question actually.
Yeah.
Please put your camera on and come here. Please show up.
Yeah, I've started my camera. Yeah, I started my camera, sir.
Yeah, go on.
I think.
Tell me, how do you
Yeah,
regenerate mitochondria?
actually, yeah, there are some works are as per Cochrane review. I was doing some Cochrane review, and I have come to know there are certain evidences of mitochondrial rejuvenation can be done in post transplant graft survival. Uh, mm, Actually, uh, I'm not able to recollect the exact two publications I've read. Sorry, that's what I want to raise this issue with you.
No,
If you
I
got
don't know
any
about that
of
so I
the
can't talk about it, I'm afraid.
Okay. Thank you. Thanks. Dr. Karthik.
okay, sir.
Karthik
Thank you,
Kulshrestha.
thank you.
Yeah. Hello, sir. I'm Karthik from Kochi.
Yeah, put your
So-
camera on, Karthik.
Yeah, sure. Sir.
With a respect to the
No,
professor.
it's okay, I can hear him. Maybe he doesn't want to put the
Yeah.
camera. Yeah.
That's fine, sir. It's always great listening to you, sir. I've heard your talk when you were in Kochi also for the HPB training program once. So my question is, sir, with so many transplant centers coming up in India, and you know we have a lot of transplant centers in each city right now, and the volume is getting divided. So do you think it will affect the quality of training that we are getting right now, because there's so many low volume transplant centers and the high volume transplant centers obviously will have some kind of decrease in caseload because of the so many centers coming up? Isn't it better to have more high volume centers, concentrated centers for transplant?
Yeah, I mean, in India, I think that's where those regulations may be quite difficult. I think the government body will have to come up. If you look at the Western countries, I mean, if you take for UK, the number of transplant centers is regulated by the government. So they have regional centers, and you can't have more centers. But in India, I think those they are very difficult to bring about that sort of rules, because the private hospitals obviously would object to that. At least what the government can do then is to have a large setup in government facilities with transplant for training, which is just like currently, if you see, most surgical training are probably best in large government hospitals. So transplant can also be taken on like that in the government hospital. So the private institutions, if they are small, won't be training centers. And by default, they won't become training centers because people won't go there because they won't get trained. I think everything will adjust itself, actually. We will go through a phase where there will be many centers. Over a period of time, maybe it will focus into many large centers. People may just join together. Or the government itself will form large centers, so the problem that you're talking about will be sorted out.
Thank you.
One last question. Anyone from the audience before we'll let Professor have his lunch, dinner, and then rest of his free time. Anyone? Raghunath, you want to say something? You can.
Hi.
Yeah.
I was just amazed listening to Professor Rela. This is the first time I'm actually listening to Sir. I was just going back to a question raised by somebody earlier about him doing one wall going away from him. Would that be backhanded, the right vein that he mentioned?
Yeah, it's not actually backhanded. It's from inferior upwards and upward from above downwards. You only if you see the axis of the right vein anastomosis is from above to below. It's a craniocaudal, and therefore you don't have to go backhanded. But if there is a transverse incision, if you're going away from you, it is backhanded, and therefore I don't do transverse incisions away from me. So it comes towards me, which will be forehanded. All my anastomoses are actually forehanded.
Okay.
All right. Thank you.
Thanks.
Ashwin, back to you, and I just want you to give just an overview of what is in store in the future in this series.
Yeah, so Prof, again, thank you so much. After a long day, after the pediatric transplant, we have taken an hour and 3/4 of your time, but it's been a very inspiring and quite a scintillating talk, so to say. So as the first of a long series of talks on liver transplantation. The next one is going to be is about training. Should it be in India or should it be abroad? We have two such surgeons, one who's been trained in India, like what Prof was saying, and the other who's trained totally overseas and has come back. So we can have a debate, and we can further elucidate the answers to what the residents were asking. We will also be going through the other etiologies, contraindications. So we're going to have about 10, 12 topics. And then when you do find the time, Prof, it would be great for you to join in and maybe participate in it as well.
Sure. Okay. Thank you.
Thank you, Professor Rela. Thanks so much. And it's really wonderful listening to you. We also want some HPV lectures from you.
Sure. I'll join in for more lectures.
Dr. Ravi Shankar, you have anything to say? Dr. Ravi Shankar is the CEO of Lilavati and the thoracic surgeon, sir. Would you like to comment?
Dr. Rela and Dr. Rela, you may remember I had met you in your institute. I'm Dr. Jayanti's brother.
Yeah.
And
hello.
I had come from Lilavati Hospital.
Yeah.
And you had done that 1-month-old child whom we had diagnosed in Lilavati and started CRRT before we transferred the child. Since then, of course, we've done about 5-6 transplants. And though I'm a heart surgeon, I've taken a lot of interest. I've been attending all the marathon sessions, and we actually generated 2 cadavers and had 2 cadaveric transplant and 3 live related. They all did well, but it's a very fascinating surgery, and congratulations to you and your team for doing that child, just 1 month old, the smallest in the country at that time. Thank you.
Thanks very much. Thank you.
Thank you. Thanks once again. We had over 200 people watching you live, sir, and it's been wonderful. And we wish you have a great weekend, and we'll see you again next week. Thank you all so much. Thanks for being a part of this program. Thank you.